Morning, evening, afternoon, everyone. We'll just wait a couple of minutes while the meeting starts and people might join. We'll give it another minute or so just to make sure everyone who wants to be here is here. Okay, let's kick off. So, welcome everyone, no matter what time zone you're in, or if you're watching this post hoc, which probably means you're also in a time zone. My pleasure to introduce Associate Professor Shamini Barnard from Curtin University. Shamini's been at Curtin for about 3 years now. Prior to that, she was in England, working in the public health sector there and with King's College as well as an academic affiliation. Expert in analysing large public health data sets. And today she's going to tell us about some of the West Australian specific research she's been up to in trying to cope with our giant state, which is bigger than the UK, bigger than Germany too, I think. Bigger than most of Europe. Anyway, Shamini, take it away.
Thank you, Andrew. So today I'm going to talk about a project that we're doing here in Western Australia called the Rural and Remote Health Outcomes Monitoring Platform. And based on where we are with the project, I'm going to talk about the design, development, governance of this multi-provider virtual clinical quality registry that is focused on Western Australia, but specifically the rural and remote population within Western Australia. But before I get started, I'd like to acknowledge the Whadjuk people of the Noongar Nation as the traditional owners of the land on which I'm speaking to you from today, and so is Andrew, and pay my respects to elders past, present and emerging. This is a photo of a sandbar in a place called Joondalup, which is actually Point Walter in the English language. And it's a really spiritual place for Noongar people who often gather there on weekends. So it's a beautiful, beautiful country that we are lucky enough to live in alongside our Aboriginal population. So the ROMP project, this is a collaborative project between health service providers and university. It was conceived by an organisation called the West Australian Rural Research and Innovation Alliance, or WARRIOR, which is an alliance of health service providers and academics who have a shared interest in tackling some of the challenges that health challenges that are faced by rural and remote populations. The partners within WARRIOR and within the ROMP project all value shared and transparent data. And so the idea was they identified a gap, the fact that they didn't have shared and transparent data between each of these siloed services operating within rural and remote WA. And they wanted a project that would help inform policy and improve patient pathways, support better access to care and enable better, more effective resource allocation. So I was brought in to lead the application for funding, and we were successful in a funding application. So this project is supported by the MRFF. So that's the Federal Government's Medical Research Future Fund. So it's a 5-year grant, and we've recently received additional funding to support and advance what we're doing. Before I get started, I just wanted to, I had a map of Western Australia there with our service partners, which it probably doesn't give you an idea of how big WA is, but it's huge. And while we've got service partners that deal with hospital services, primary care, pre-hospital, so ambulance services, and rural flying doctors, so the aeromedical services in WA, as well as Aboriginal medical services, specifically from the Pilbara, and we recently started onboarding a Southwest Aboriginal medical service. WA is really broad, but I thought a point I'd make is complexity, the cultural complexity and diversity within WA is vast. So even just in the Noongar region, from where Andrew and I are coming from today, this map shows the different dialects that are spoken across the Noongar region, which is just in that southwest corner, and that there's actually 3 different districts within that area. Where Perth is the dot, just in the middle, where Whadjuk country is shown there. And so we are dealing with a very culturally diverse area as well as a vast area. So what is our problem? Well, we're delivering services and healthcare across 2.5 million square kilometres in WA. So I believe it's the largest landmass under a particular health service provider. There is, because of the vastness of WA, there's reduced access to specialist care for people that are in the regions. WACS, which is the WA Country Health Service, so the health service that delivers to rural and remote areas, is actually responsible for 70% of the landmass of WA, or health services within 70% of that. And we have a really high burden of chronic disease in our rural and remote areas. So because of the size of the area, it's patients are often touching base with multiple care providers across primary care and hospital, but also land and aeromedical retrieval. But we also have a virtual command centre as well, which is operated by the WA Country Health Service. The virtual command centre delivers video conferencing, provider to provider video conferencing for specialist care to improve access to specialist care in the regions. But our issue is that there's no sight across all of these different health providers in terms of what's happening to patients. Existing quality registries in WA are single site. They often require additional data entry from providers, so coming down to more granular clinical data. And because they're single site, it's difficult to track patients across multiple organisational boundaries. Historically, we've seen, we see disproportionate health burden among our Aboriginal population, but we also see a lot of exclusion of Aboriginal people from the design and monitoring within these sorts of infrastructure. So it's something we'd like to address with this project. As I've mentioned, we've got fragmented systems. At the top of this slide, we've got an example patient journey. I think everyone's familiar with these sorts of things as people move between different service providers along their health journey. In WA, we have no shared identifiers between these services. We have variable data standards, different ways that we document. Some providers still aren't using electronic medical records, for example. So there's a lot of varied data maturity between our service providers. Because we've got multiple data custodians across a patient's health journey, we have complexity in the governance and the legal frameworks that we need to operate within. And our Aboriginal communities are pushing to operate their health data under Aboriginal data sovereignty, which means the community retains control of their data and governance around how that is presented and analysed and what is collected. So it's a complex environment that we're operating within, and lots of different things that we need to consider. But importantly, the current situation is that it's very difficult to see longer term outcomes for any patient moving through this system. So what is the Rural and Remote Health Outcomes Monitoring Platform, or ROMP for short, better or worse? It's an acronym that's stuck. It's a virtual registry that's aggregating routinely collected clinical data. So we're not asking for anything additional from services. We're looking at multi-providers, so a linkage project that links data between providers. Obviously, we're collecting longitudinal data, tracking those patient trajectories across that continuum of care. It's not complete continuum of care, but we're growing in terms of the different providers we're onboarding. And it has a dual purpose. We'll be looking at clinical quality around transitional care and adding long-term outcomes for existing clinical quality within sites, and also a research data asset. So the image on the right-hand side of this slide is fairly complex, but at the top you've basically got ROMP, which is an information platform, which has data dashboards and insights for providers, that reporting and analytics in the research space that's aiming to drive better decisions. We've got a lot of different data sources that are coming into that platform, and the idea is to look at a composite measure of healthcare quality that looks at system capacity, care delivery, and health outcomes as well. And so that composite multi-level system-wide assessment is novel and new, and it's ambitious, and it's what we're trying to do. There are two clear deliverables within the project. One we've named ROMP Interactive, and that's that provider-facing or health service provider facing dashboard, which will operate as a virtual clinical quality registry platform that will enable the routine monitoring of healthcare quality indicators. Now, we're not trying to tell services how to measure their quality indicators. They already have safety and quality teams that are doing that. What we bring in is the additional longitudinal outcomes routinely for their existing quality indicators, plus another aspect of between provider transitional care quality outcomes that they wouldn't have normally seen. But importantly, there's the research environment, which is there to deliver composite sort of health journey assessment research for our rural and remote populations. And that's going to be in a secure, de-identified research platform. And the questions that we ask of that data are driven by our committees, which I'll talk about in a minute. Which are made up of health service providers as well as researchers. So obviously we can't do everything for everyone, and we've had to focus and prioritise what we're looking at first as a platform. This was prioritisation process was fairly extensive as we were working across our different health service providers to work together on what's most important to start with. But we landed eventually on cardio-kidney metabolic syndrome. This is a syndrome around interconnected cardiovascular, chronic kidney disease and metabolic conditions, including type 2 diabetes and type 1 diabetes. But the reason that we landed here is it's a syndrome with the highest prevalence and mortality burden in our rural and remote network. There is substantial burden within the Aboriginal population as well. And generally, people who have this collection of conditions are seen across multiple providers, and therefore it's relevant for this type of platform. We've also seen in 2022, the American Heart Association formally developed a framework around providing an indicator around CKMS, or cardiac kidney metabolic syndrome, and we would like to drive an understanding of best quality indicators for this condition or this group of conditions. So CKMS is where we're starting. I'm going to talk now a little bit about governance, consumer engagement and data sovereignty within the platform. So a very simplified governance structure. We have an overarching advisory committee for the project that consists of executive members from or even CEOs from across the health service providers on the project, as well as consumers and independent members. Because of the accountability structures in the grants that are awarded, that it really sits with the lead investigator. The accountability will sit with the CIA. So this committee is advisory at this stage. But they're there to give advice on overall strategic direction of the project. And then feeding up into the advisory committee, we have three key committees. The Health Service Provider Committee, which is made up of health service provider safety and quality managers, looking at what we need to be, what's important within the platform, what data to collect at this stage of our development, and how we'll present it. We also have a research committee that's driving the research questions, and an Aboriginal Leadership Committee. The Aboriginal Leadership Committee will govern any aspect of the project which involves Aboriginal people, and me as a lead of the project, I'm there to facilitate the direction given by the Aboriginal Leadership Committee around Aboriginal data. So moving on to consumer engagement, this is where we're at so far. So we're 18 months into the project at this stage. We have reached out to over 60,000 people across West Australia through different consumer groups. And we've received a lot of feedback. So our outreach involved surveys and invitations into meetings to have conversations as groups, as well as just inviting emails in to let us know what's important. Obviously 60,000 people didn't get back to us, but we got a fairly good amount of feedback. We also reached out to a lot of health service providers in the region, so clinical specialists, to talk about what was important to them. And what we learned, there were three key things. One was around access and availability of care. There was another around continuity and coordination of care. And there was a lot of conversations around the role of digital care. So people in rural and remote WA wanted better access to appointments. It's very difficult to secure appointments. There's long lead times. People have to travel long distances. There's the availability of local services is limited, as you can imagine, in a geography this large. People really expressed a strong preference for local care or care delivered closer to home. People talked about seeing the same providers over time and how important that was to them, which can be challenging, particularly with outreach services. And also talked about a strong support for improved information sharing and coordination. There was people valued what's working in digital health, and those that had experienced not having to travel to specialists because they were able to access the command centre spoke very positively. So that's that provider to provider specialist care through video conferencing. After our initial outreach around consumer engagement, we have formed two consumer groups. Initially, we looked to form one, but our Aboriginal group expressed a preference due to the importance of focusing on Aboriginal data sovereignty to have their own consumer group. But the work, there are Aboriginal people who are on all of our committees as well that feed up, so it's not siloed into the Aboriginal leadership group and consumer engagement. But I'll talk a little bit more in a couple of slides about the structure around the Aboriginal leadership. But we have one particular group, consumer group, based on Aboriginal needs and a non-Aboriginal focus. We actually have 9 consumer and community members. We have a 1-year term for each of them, and we meet monthly with our consumers. We have fairly good regional representation, but we're trying to get a little bit more. We tend to get good representation from people closer to Perth, so it's more challenging to get some of the outer regions involved. But we have a lot of people with lived experience of cardiovascular, kidney and metabolic syndromes, as well as mental health and others. Okay, so speaking a little bit about Aboriginal data sovereignty. So I spoke about the Aboriginal leadership group, and what's really important is that we want to make sure that that we are delivering the project under the principles of Aboriginal data sovereignty, and that means that the Aboriginal leadership group will lead the facilitators of the project in delivering any of the output around Aboriginal communities. So we have a separate governance layer. Anything that we do goes through a specific Aboriginal health ethics committee in terms of ethics applications. We're ensuring that any reporting and dissemination of findings is overseen and signed off by that group. There's a very key shift that's going on at the moment from shifting away from talking about the problems and the gap and celebrating how some of the strengths in our Aboriginal communities. So there'll be community authority over the scope of what we're doing, and absolutely co-design with our Aboriginal medical services and community around the indicators of what good looks like. And importantly, and from a technical perspective, withdrawal provisions. So ensuring that at any point that data can be withdrawn from the platform safely and secured back into community if people aren't comfortable with it remaining in there. What does that look like? We have a central leadership committee that's based in Perth here, which then advises on how we reach out into the regions. So again, we have Aboriginal staff who will be doing the work out in the regions with Aboriginal communities, and also community organisations as well, and ensuring that the principles around self-determination, collective ownership, data governance, data for rebuilding, and data that's ethical and secure, and data that's contextualised appropriately is something that we're collecting and making sure is delivered appropriately. So that's what that's the structure of our Aboriginal approach, but the Aboriginal group will present on their own development. I'm sort of just doing a light touch on this. Go into the nitty gritty, the ROMP platform. How do we come up with what the data set for the ROMP platform looks like? And this is for CKMS specifically, or each domain specifically. We look at it from a few different areas of what needs to be in there. The research team does some scoping reviews to look at what's already known around what needs to be collected to understand quality and outcomes for cardiovascular, kidney, metabolic diseases, and also where the gaps are in rural and remote care. So a lot of quality indicators are developed for metropolitan settings and really aren't appropriate for rural and remote care delivery. So the research team is focused on understanding what's right from what's already existing in the literature and the gaps. And then we have our health service providers and other provider teams that are identifying their data internally. So what is there, what's available, and then doing a quality assessment on that data. So what should be in the platform and where we lack quality. And we have a structure around how that quality of the data quality is being assessed. And then the other thing we need to do is stakeholder assessment. So that's with the providers and obviously consumers as well, but understanding what providers need to know to deliver better care and letting consumers inform that as well. And so that's how we identify what content needs to go into the platform. And then how do we bring it together? I think I mentioned earlier, we don't have a common identifier across our organisations, and the governance between our organisations or within each organisation and privacy law prevents open sharing of clear text. So, for example, my name and address and date of birth. So we use a technique called privacy preserving record linkage. And in privacy preserving record linkage, we're able to link the data using a probabilistic method in a way that the individuals identifying records never leave their organisation. So we use a Bloom filter. The technical process is we install a program within each health service provider where health service providers can identify the cohort that needs to go in, but that cohort whatever comes to us is just zeros and ones, and we're able to do the linkage on that zeros and ones and create matched record pairs between service organisations. It's a fairly technical process that I won't go into, but it's I can talk about it another time. So that linkage means that more providers are able to get on board with this platform and they feel more comfortable about the process in which the linkage is occurring. We have two different environments that the data comes into. There's a linkage environment where those zeros and ones come into, and that is completely separated from the research environment. So the people that do that linkage, even though it's only zeros and ones, they will never do the analysis of the content data. They'll do the linkage and then leave that there. Then just the content data and the linkage keys are moved over into the research environment, which we manage under ISO 27001 certification. And from there, we'll push out the dashboards and any research. So that's it centrally at Curtin, the environment for this project. And I think, what we are trying to do over the next few years is develop more sophisticated pipelines that can automate a lot of these processes so that it's less resource intensive on our service providers. Fairly basic overarching framework for quality and improvement research is that we'll be looking at structure, process and outcomes. Really looking at that system structure, the processes of care delivery, but focusing on care transitions within that process stuff, really because we're not trying to duplicate anything that's being done at site level. We're looking at adding additionality, something that couldn't be done within the site. And then obviously anything around those outcomes where health service providers would not necessarily see what happens when the patient leaves their service. So in terms of dashboards, they will sit outside of organisations at this stage of the process. They will sit in a secure environment for providers to access. Actually within Curtin at this stage, but the process of developing those dashboards will be co-designed with them and iterative. So each provider will have their own dashboard because they all have different needs. We're likely to have an overarching burden of disease dashboard, something relevant to all of our providers, but have provider-specific outputs as well. But we'll be working closely with providers to identify their needs, build the drafts, make sure they're involved in the review and sign off before it's refined and released. And our governance committees currently, the work we're doing is we're trying really hard to make sure that providers are engaged in this process. So I've seen many times reporting released and just it lands very flat because either at an organisational level there's not an identified need or there's not been that work in co-design in the development of that. So our dashboards will look at, clinical quality, as I mentioned, around those care transitions, but anything we can look at in terms of patient outcomes, adding value to their own clinical quality indicators and system efficacy. Okay, so ROMP Secure Research Environment, that is the research place that our researchers will be accessing. This is a trusted research environment that we operate already within Curtin. There's an access pathway that involves data access agreements and governance over that. We also review the analytical scope. The infrastructure, we have a VDI, a virtual desktop infrastructure, where we have multi-factor authentication and role-based permissions. It's ISO 27001 certified. Our software, it's R and Python, but I think Stata is in there and anything else on demand. And we operate version control and obviously look at statistical disclosure, control review, and the 5 safes on any output. Okay, final part from me is really around the broader implications of the project. So Australia is moving towards a common data model and an EMR. We would like in Western Australia to use ROMP or this particular project to understand how we can inform our EMR. So anything that we're developing around what's required from a quality indicator perspective, what we can see in the research environment around what's important for outcomes, we'll be able to give some structured feedback to health services around development of that EMR. And that's already coming in now in these early stages when we're getting a lot of registries within these services approaching us to say, could we add this in and how would that work? And working through those technical pieces, there's clearly at that point we're able to identify what we could do better in our EMR collection to reduce the resourcing of those particular registries. This is something we need to think about and develop as it goes on, but this is kind of a broader implication of what we're doing. But also, we are also contributing to this virtual registry development in Western Australia. So the traditional methods of clinical quality registries generally require separate data entry. And I completely acknowledge the value of some of that more granular clinical data and bespoke clinical data that can go into a registry. But as I said, that's where this sort of long-term development goal with the EMR comes in. So traditional CQRs rely on that. It can be quite expensive to run. They tend to be usually single condition or procedure, for example, multiple site maybe, but often start in a single site. There is a very high administrative burden, but it's very difficult in a rural and remote setting to around that dispersed workforce to really get those registries going. So with this virtual registry model, we are looking to look at routinely collected data, which is improving year on year, what we can get in that space. We're looking at multi-provider and the platform itself, although we're starting with CKMS, that's just the start. We'll be broadening out to the next priority conditions. I should mention that clinicians within each condition are involved in the project, or specialists, advisors as well. But the virtual quality, clinical quality registry really looks at a minimal clinician burden and is designed for patients that are moving between services. So particularly for the rural population that are often coming into metro areas, we're linking to their metropolitan service delivery as well. So it captures that and enables longitudinal tracking. So we will be engaging with the wider sort of clinical quality registry environment as the project goes on to show, I guess, what worked and what didn't work in our space. Limitations and challenges. I'm sure anyone listening to this now or watching this on a video will think of 100 different limitations around data quality, which it's one of our biggest challenges. we're lucky enough to have a fairly good administrative data record being produced by our Department of Health in WA. However, the timeliness of this is limited. So we're looking at a hybrid between, particularly for the Country Health Service, some of their more timely data, as well as the less timely administrative data around hospital episodes and service delivery. But yes, data completeness and quality does vary substantially across our provider network. And for example, some of our providers are really aeroplane services that, airline services that provide medical services. So there's a lot of variation. So we're on a journey with that. There's a huge amount of governance complexity with so many providers. Thankfully, this came from the providers rather than the researchers in terms of needs. So people are playing fairly nicely, and any limits, we do have some complexity, particularly around providers that have contractual obligations between them in terms of what data can be shared and what can't. So the process around ensuring that we prevent data leakage and that the appropriate data is seen by the appropriate groups needs to be very robust. So we're working with our teams on that now. Capability and workforce. This is you have to front load a lot of the resourcing and getting this right. And so we are lucky enough to have received a little bit more funding to help us do that. But as you know, these projects are time limited in their funding. So we have a sustainability piece, a work stream around sustainability and how we sustain this platform going forward. And there are a lot of different options for us here in Western Australia. So we're working through those and looking at where that sits with our strategy and what the platform wants to do. But realistically, if there's a huge return on investment for providers, they may well want to fund it themselves. Realistically, I'm not sure that it's going to be very easy to identify the ROI on a product like this. So we'll see how that goes. Infrastructure, heterogeneity, we have completely different systems across organisations at completely different levels of maturity. So we can't standardise an extraction, but we're working towards that and automating it. And at the moment, this is a pilot scope. So we are balancing the complexity of our development with the need to show value. So that's something that we have a little bit of constraint around. And obviously, this isn't a causation. We don't show any causation. This is an observational linked data platform. So it needs careful contextual interpretation, particularly in the quality improvement space, which is why we're working so hard with our providers to develop those dashboards that are well contextualized for their needs. Last couple of slides, implications for the field. Well, we'd like to demonstrate the feasibility of a multi-provider virtual registry model for geographically dispersed and resource constrained settings. I think this is really important and directly transferable to other domains and jurisdictions. WA is particularly interesting as a jurisdiction because we don't have an awful lot of movement in and out. We're quite remote as a state, or isolated in that sense. So it's a good one to start in, and we don't have a huge amount of providers. So it's important that we get this right in this slightly simpler setting, and then think about how it might work in other jurisdictions in Australia. We're hoping to provide a worked example around Aboriginal data sovereignty and governance. So it's important to us that we follow those rules and learn from them and continue to publish our findings around what worked and didn't work in this space. And we're working closely with other Aboriginal organisations who are on this journey in Western Australia as well. I should mention that the Aboriginal Data Sovereignty, I think it was 2021 was the first sort of push towards that. So it's fairly early in its development. So we're working to hopefully show some value in operationalised ADS. For clinical quality improvement, we've got this longitudinal cross-provider visibility. That's something that's new and novel, and I think that's really important around those transition failures. It's something that comes up time and time again when you talk to rural and remote people. And for EMR development, that feedback mechanism around improving clinical data collection at source and shifting that relationship between data infrastructure and EMR systems. So where we are in our 5-year plan, we're really just starting to develop the products. Data applications are in with Department of Health, and we're hoping to have data linkage early next year, the first data linkage, which will then be updated routinely from there, and the first outputs at the end of 2027 in terms of dashboards and research outputs on the actual data. We're obviously producing research as we go around the scoping reviews, as well as some of our consumer engagement and qualitative work. So in summary, I think this project really looks to address a fundamental gap in rural and remote health infrastructure in WA, and that's longitudinal and cross-provider visibility of patient outcomes. It's custom-made, it's hybrid infrastructure, and it's built specifically for governance, technical and ethical requirements of our partner network. Aboriginal data sovereignty will be operationalised and not just a statement. And that's important. And then we are also looking at designing and developing novel processes, learning iteratively and improving the data ecosystem that this platform draws from. So we're hoping to continually learn. And this is a proof of concept, a pilot model that we're hoping to inform wider virtual clinical quality registries nationally. And finally, this is the project team at this stage where we're expanding. So myself, we've got Emma Zilko, Karen Ugal, Libby Thomas, Marisol, she doesn't like to be called Leslie, Marisol Luga-Gavidia and Kaylee as our team who are employed on this particular project. But we have a cast of many more. This chief investigators are listed here. They come from university and all of our health service providers, but we also have committee members. So it's a vast cast of people, and there's more information about the project available at www.rhomprompt.org.au, and please get in touch if you need anything. Thank you.
Thanks very much, Shamini. I'm not sure if a couple of people online have questions. I might kick off with one while we in case they're typing as we speak. So just to check my understanding, a lot of the consumer feedback related to health systemic problems, right, that the ROMP project can't solve directly, but and just to check my understanding, so this platform, the aim, however, is for this platform to enable those issues to be addressed. Is that correct?
Yeah, to highlight the data that allows those issues to be addressed. So there's longer term outcomes, issues around satisfaction. I wasn't explicit around the exact data sources that are coming in, but we'll be looking at patient reported experience measures and outcome measures as well within the platform. And so, yes, we'll be looking at the activities that drive better outcomes and exploring those further. So that's where we're an information provider that should, in theory, if the connections are right, inform services on where they could improve care.
Gotcha. And I have a second question, which is coming from my more technical background. So the Aboriginal data sovereignty, you're operationalising that as sort of wetware, as in human committees and governance. Is there any software features or enablers that you've considered that might help in that regard? I'm not sure what they would be, but I don't know. Have you thought about that stuff?
Well, not software specifically. There are some challenges just around the providers of primary care within Aboriginal medical services provide primary care to Aboriginal people within communities, and those services operate using two different primary care platform providers, as in data platform providers in Western Australia. So there are complexities that already separate that data out in the collection of that data and potentially how we bring that in. Now that almost enables us to have that separation principle in enabling flagging of data that may be able to come back out if there's that. I talked a little bit about data. One of the terms is data is your data is your relative, so you protect it. So we need to facilitate those. Now, I'm not aware of any existing software within the market that can do that. So this, as a pilot, will think about the different ways that can be developed. So that's one thing. In terms of operationalizing the outputs, that's very qualitative and understanding what good looks like and how to reflect what those outcomes should be that are reflected within that presentation.
Yeah, tricky stuff. Okay, I think there's no other questions from online, so I'll wind up the recording here, and thank you very much, Sharmini.
Thank you.